and good afternoon, good evening to all others who are joining from rest part of the world. Today, our guest speaker for the day is Dr. Maria Domenica Capellini from Italy, and she's going to lecture us on state of the art in managing thalassemias. This webinar is brought to you by Mumbai Hematology Group, supported by Bristol Myers Squibb, Accurent, Natco, Unipath, Lucien, and Nirwin, and managed by Perfect Square. I thank Dr. Hetuk Shah and team BMS, Dr. Amit Chip and team Accurent, Mr. James Rajkumar and team Natco, Mr. Srivastav and team Lucien, Mr. Anil Verma and team Unipath, Mr. Paresh Prabhugaonkar and team Nirwin, Mr. Yash, Mr. Kalpesh and the team Perfect Square, Executive Committee of Mumbai Hematology Group, our chief guest for the day, Dr. Aryan Jain from Chandigarh, our guest speaker for the day, Dr. Maria Domenica Capellini from Italy, all our discussants who are themselves very eminent hematologists and hemato-oncologists, and you participants for spending your Sunday morning, afternoon, and evening from whichever part of the world you're logged in. Let me give a flavor of our next weekend activities. Next Saturday, that is 1st of June 2024 from 7 p.m. Indian Standard Time and 10:30 a.m. Argentina time, we have Dr. Astrid Pawlowski from Argentina speaking to us on bispecific antibodies for relapsed refractory NHL. And the following day, that is Sunday, 2nd of June 2024 from 11:30 a.m. Indian Standard Time, we have Dr. Pushpanjali Oja from Ranchi speaking to us on diagnostic challenges in hemophilia care, past, present, and future. Let me introduce our discussions for the day, and we have a galaxy of them here displayed in alphabetical order. To start with, we have Dr. Avinash Kumar Singh from Patna, Bihar, Dr. Abhilasha S. from JNMC, Belgavi, Karnataka, Dr. Aditi Shah Kaskar from HCG Hospital, Borivali, Dr. Anand Prakash from St. John's Medical College Hospital, Bengaluru, Dr. Ashutosh Panigrahi from AIIMS, Bhubaneswar, Dr. Chandima Thevaraperamma from Colombo, Sri Lanka, Group Captain Dr. Harshit Khurana from Armed Force Medical College, Pune, Dr. Neemia Thanda from North Okkalapa General Hospital, Myanmar, Dr. Humaira Nazneen from Dhaka Medical College Hospital, Dhaka, Bangladesh, Dr. Kapil Garg from SMS Medical College, Jaipur, Dr. Liza Pulsara from Avinash Cancer Clinic, Pune, Dr. Narendra Kumar Chaudhary from AIIMS, Bhopal, Dr. Nita Radhakrishnan from Postgraduate Institute of Child Health, Noida, Dr. Omkar Khandkar from TN Medical College and B.Y. Nair Charitable Hospital, Mumbai, Dr. Pritam Singha Roy from Tata Medical Center, Kolkata, Dr. Priyanka Samal from IMS and Some Hospital, Bhubaneswar, Dr. Rajat Bhattacharya from Apollo Multispeciality Hospital, Kolkata, Dr. Sandeep Nemani from Sri Siddhi Vinayak Ganpati Cancer Hospital, Miraj, Dr. Sandeep Bartake from Bharati Vidyapit Medical College, Pune, Brigadier Dr. Sanjeevan Sharma from Ladakh, Dr. Shruti Kakkar from Dayanand Medical College and Hospital, Ludhiana, Dr. Sonali Mohapatra from AIIMS, Bhubaneswar, Dr. Sravaya Chituri from Little Stars Hospitals, Hyderabad, Dr. Suma TL from SCG Hospital, Bengaluru, Dr. Sweka Lunkat from Avinash Cancer Clinic, Pune, Dr. Smita Shanbag from Father Muller Medical College Hospital, Bangalore, Karnataka, Dr. Yi Montan from North Okkalapa General and Teaching Hospital, Yangon, Myanmar. Now it's the time to introduce our very special guest and chief guest for the day. We have with us Dr. Aryan Jain. Dr. Aryan Jain is MD in Internal Medicine and DM in Clinical Hematology, Associate Professor at Department of Clinical Hematology and Medical Oncology at PGI Chandigarh. It's my privilege to welcome Dr. Aryan Jain to inaugurate our webinar and give some words of wisdom. Over to you, Dr. Aryan Jain.
Thank you, Dr. Amit, and thank you, Dr. M.B. Agarwal, sir. I welcome you, all your wonderful participants on this yet another exciting session of enriching our knowledge of hematology, which this platform has been doing relentlessly for past so many years, and we all know how much we have gained through this. So, as a address to all of you, I would first start with my as a message to the people who are contemplating to be hematologists. I would say that in the past 7 to 10 years of my practice in this medicine, I realized this almost every day that probably this is one of the most wonderful branch of medical subspecialties to be in with, because this branch gives you so many therapeutic interventions and so many drugs to play with, to meddle with, and to impact the lives of our patients and their caregivers as well. So so this is one branch which just can transform the lives by the stroke of your pen, just one prescription, and 2 weeks later, very frequently the patient will come back and say to you, I have never felt this good in the past 6 months or 1 year that I have felt now. So I think this is one of the best fields of medicine to be in with. For those colleagues who are trainees and already established and have chosen hematology as their career, I would just like to say that at least the 4 qualities which my seniors have kind of inculcated in me, and I would say that these help you and help your colleagues and patients. One quality is the thirst for knowledge. This is a very, very rapidly evolving field, and the science is changing very fast. So that thirst of knowledge has to be there with you throughout your lives. And I must say that platforms like MHG fulfill that, quench that thirst in a very, very user-friendly and just at the click of your mouses, and you all must take advantage of this platform as much as you can. The next trait which I would say is very important in this branch is comprehensiveness and detailing, because most of these the disorders which we deal with are kind of systemic disorders. These are blood disorders, and blood is there in the entire body. So the patients will come with you with multiple complaints, and I would say that not only just look at the reports, one, see the patient as a whole and what problems they are having, and the acronym which we use for each issue or problem, just use the subjective objective assessment plan based format, and you would not miss upon the minor things, or sometimes they actually may be very important and major, but sometimes you tend to overlook them. But if you are using that stepwise pattern of SOAP-based assessment for every issue which the patient is having, probably you will be in a better way, you would be helping your patients. The next trait which I would say is also very important is individualization of therapies. This is a branch where we have so many guidelines, and we try to stratify our patients and into various subgroups and apply the guidelines and textbooks on those. But very frequently, or more frequently than what you would imagine, the patients don't read the textbooks. So guidelines are there to support you, but at the same time, you need to learn that art of medicine in individualizing your medical knowledge to the specifics, the socio-demographic specifics, as well as their disease characteristics, rather than just throwing the book at the patient. So individualization is very important. The fourth trait is that in this field, actually, there are more unknowns than knowns. So being research oriented and trying to have that desire in finding the one, questioning the established principles and dogmas of the practice of hematology, one, to question them, and two, to find out answers to the unanswered questions. So that research oriented trait is also very important, and that would help you, all of us, in kind of improving the quality of life and science as well. So just repeating, 4 traits: thirst for knowledge, detailing and comprehensiveness, individualization, and being research oriented. Lastly, to all the senior faculty colleagues and teachers who are there or are listening, I would just like to take this opportunity to thank you for accepting me as a part of this wonderful fraternity. And it is because of the knowledge which you all seniors in the community, we keep on interacting and learning from each other. And it is because of the traits and tricks of the this field which you have given us that that we are here, and we do whatever we do is actually a continuation of what has been taught by you all. So thank you. And with this, I welcome you all to a very interesting session by Dr. Maria. Over to you, Dr. Amit.
Thank you, Dr. Aryan Jain, for that 360-degree view of hematology. Your 4 points were so valid and fantastic that will really help us in our practice as well as all the junior colleagues in building up their practice. Thank you so much for being with us as our chief guest. I now share our screen again. So now it's a time to introduce our guest speaker for the day. We have with us Dr. Maria Domenica Capellini from Italy. Dr. Maria Domenica Capellini is full professor of internal medicine at University of Milano, Italy, at the Department of Clinical Sciences and Community Health for the last 20 years. Since 1999, she has been the chief of Thalassemia and Hemoglobinopathy Center at Milano, Italy. She is scientific advisor for the Thalassemia International Federation and contributed to their meetings. She was instrumental in establishing the guidelines for the treatment of thalassemia published by Thalassemia International Federation. She has done extensive research in the field of hereditary disorders of red cells, especially thalassemia. She has been the invited speaker and chair for various prestigious meetings and events across the globe. She was the president of European Federation of Internal Medicine. And today she is with us and she's going to lecture us on state of the art in managing thalassemias. Well, thank you so much. Over to you, ma'am.
So can I share my slide?
Yes, ma'am.
Can you see them?
Yes, ma'am. Full screen mode, ma'am. Yeah, perfect, ma'am.
Okay. So first of all, I thank you all and I thank you very much for the introduction. It's always a pleasure to be with you. And what I'm going to discuss with you in the next coming hours or so is the state of art in managing thalassemia. So these, can I move? These are my disclosure. And as it was well introduced already, we have supportive care for thalassemia quite well established, such as red blood transfusion, iron chelation. In the past, much less now, but splenectomy was one approach to treat thalassemia, and in some cases hydroxyurea. Although this current supportive care improved the survival of thalassemia patients, however, is not optimal because it requires continuous monthly or even less every 2 weeks going to the hospital for the transfusion. There is a need to have sufficient blood available, and iron chelation require adherence every day. So although the situation during the last 20 years is improved, nevertheless, there are some unmet needs, particularly focusing on improving the quality of life of the patients. And this means to manage effectively the chronic anemia, reducing as much as possible the burden of blood transfusion, and also to plan a treatment in order to prevent or ameliorate the comorbidities which are common in patients treated with the standard of care. We know and we learn clearly from the non-transfusion dependent thalassemia patient, we know that increasing the hemoglobin level, it goes with a reduction of morbidity. In this curve, you can see the percentage probability of multiple morbidities, and you can see that patients with more than, let's say, 9 gram, but even better, more than 10 gram, they have much less probability of having morbidities. And of course, we can achieve that by transfusion, but the transfusion bring with them other complications. So we want to try to correct the anemia, avoiding as much as possible the transfusion. And since the 80s, I was involved on that. There was a kind of tentative to increase the fetal hemoglobin, which could be a way to correct the anemia without transfusion. But the experience with different agents, such as azacitidine, even hydroxyurea, butyrate, or others, were not really encouraging. They had a lot of limitation, and just inducing the production of fetal hemoglobin with drugs was not the right way to go. So let's see what other possibilities have been developed along the last 10, 15 years. And this is a slide which summarizes actually the novel drug design for rare congenital anemias, not only for thalassemia, but I will focus on those who are definitely part of the scenario for the novel treatment of thalassemia. And they are, thalassemia is indicated by a pink square. Let me start with the correction of genetic defects. We know that thalassemia is a monogenic disorder, particularly beta thalassemia, and the most, let's say, in theory, easy way to correct the disease is to correct the gene defects through the gene therapy. Excuse me. There are two approaches for gene therapy. One is gene addition, which means to transduce the defective gene with a normal gene into the stem cell of the patients. The other one is to modify the hematopoietic stem cell of the patients to correct the defect in some way, and sorry, and in this way we may call this approach genome editing. I'm not spending too much time on gene addition because you will see at the end of this part a list of ongoing clinical trials still pending in Europe or in other countries where it's not yet approved. But what I want to focus on is the genome editing. In May 9, so 1 week ago, 2 papers have been published in New England Journal of Medicine, one for severe sickle cell disease and the other one for transfusion-dependent thalassemia using genome editing. And that's something which recall the possibility of increasing fetal hemoglobin through a gene approach. We know that elevated levels of fetal hemoglobin, such as in nature in subjects with persistence of fetal hemoglobin, are associated with a reduced morbidity and mortality in transfusion-dependent thalassemia. So this is the principle. Many researchers were focused, as I mentioned before, through drug use, but being not successful, there was a possibility through this novel molecular approach called CRISPR-Cas9. There is a possibility of correcting the stem cell of the patient, increasing fetal hemoglobin, reducing the expression of BCL11A. BCL11A is a factor which in nature is suppressing fetal hemoglobin after the first month of life. So reducing the expression of BCL11, we have the possibility of reactivate the production of fetal hemoglobin. And based on this principle, a company developed, and nowadays there are several companies working on this mechanism or this approach, but this is the one published in New England Journal of Medicine. What is done is to harvest the stem cells from the patients to send them to a proper lab for CRISPR-Cas editing through BCL11. And then the patients in the meantime is conditioned, the bone marrow of the patients undergo conditioning chemotherapy, unfortunately still using busulfan in order to suppress the bone marrow. And then the manipulated cells are given back to the patients. This is the study, the phase 3 study, are the results published in New England Journal last week. 44 transfusion-dependent thalassemia patients were treated. Actually, the total number is 48, but a few patients had a short period after infusion and they are not included in the study. So the study was evaluated for those patients who actually were treated for more than 12 months. And actually, all the participants, but 3, achieve transfusion independence with a mean already of 20.5 months. But some patients are transfusion-free for more than 41 months. The 3 patients who didn't achieve the transfusion independence, which was, of course, the primary efficacy point, one actually had a delay in response and stopped anyway the transfusion 14 months after the exa-cell infusion. The other 2 are not yet completely transfusion independent, but they reduced significantly the transfusion burden. So you can see that results are very positive, and we will know also the outcome of those who have been infused very recently, but some of them are already starting to be transfusion independent. So the conclusion from this phase 3 study is that all the participants had an early and sustained transfusion independence with an increase in total hemoglobin above 11.5 grams, and also an increase significantly in fetal hemoglobin with pancellular distribution. And the participant, of course, had a clinically meaningful improvement in quality of life. And in a couple of weeks, more data will be presented at the EHA. Of course, I cannot disclose the presentation because are still under embargo, but I can tell you that there are more consistent data on improvement of quality of life, improving on 6 minutes walk, and so and so. So this at molecular level is definitely a promising novel approach. In this slide, I try to summarize the numerous clinical trial ongoing, either for gene addition. The most are based on Betty glob gene, and they are from Bluebird Bio, using a lentiviral vector to transduce the stem cell of the patients. There are several ongoing trials, including some children age less than 12, and including also, compared to the beginning, including also patients with beta 0 genotype. And the bottom part of the slide, you see the clinical trial on genome editing, and I can tell you that at EHA, new other trial or preliminary data will be presented. So this is the state of art for managing beta thalassemia through genetic approach. But there is another possibility to correct the anemia and improve the quality of life of thalassemia patients, targeting ineffective erythropoiesis. And for this approach, the use now in the market compound is luspatercept. I don't want to spend much time on this because last webinar with you was mainly focused or completely focused on luspatercept. But for those who are not attending or for the young researcher, I just remind you that luspatercept is a first-in-class erythroid maturation agent that neutralizes selected TGF-beta superfamily ligand, and through that is inhibiting the SMAD2/3 pathway, enhancing the erythroid maturation. So this drug, which was identified by serendipity to correct anemia, underwent a huge clinical development, but I summarize in these 2 or 3 slides the final results, which prompted to register luspatercept by FDA and EMA for the treatment of anemia in transfusion-dependent thalassemia first, but then also in non-transfusion-dependent thalassemia. And this phase 3 study, the BELIEVE study, which has been published, and you probably have seen the result in detail, had as a primary endpoint the reduction through the luspatercept treatment of equal or more than 33% in blood transfusion burden compared to placebo. And in the left part of the slide, you see that 21% of the patients achieve this primary endpoint, but in a specific frame along the treatment and precisely during weeks 1 to 24. But that was a limitation because we realized that patients have start with a different level of ineffective erythropoiesis. So their response to luspatercept could be variable a long time. And when we revisited the results, looking at the achievement of primary endpoint, but during any 12-week interval, you can appreciate that the percentage of responders increase to 75, and then prolonging the follow-up of treatment, it increases at 77 at week 153. So this data confirm that luspatercept was targeting ineffective erythropoiesis, reducing the transfusion burden. The data of BELIEVE study prompted the registration of luspatercept by FDA in 2019 and by EMA in 2020 to treat anemia in adult patients with beta thalassemia who require regular blood transfusion. Just, I don't know if I presented last time this data, probably not, because were presented last December at ASH. These are data of the long-term follow-up, where in detail you can see that the percentage of patients responding to luspatercept is increasing, as well as the reduction of liver iron concentration. This slide is difficult to capture. However, I wanted to present to you and to invite you to go to the paper published by Sujit Sheth in British Journal of Hematology at the end of 2023. This is a kind of algorithm on how to approach the treatment of transfusion-dependent thalassemia patients, taking into account the possibility of treating with luspatercept, starting with 1 milligram per kg, and then assessing the tolerability and safety, and then evaluate the response, and according to the response to adapt the treatment of the patient. So you can find this algorithm on the paper. Almost in parallel to the BELIEVE study, a second study was open for non-transfusion dependent thalassemia patients, the BEYOND study. And here I present you the summary. There was also a randomized clinical trial, non-transfusion dependent patients versus placebo, and 145 adult non-transfusion dependent thalassemia patients were enrolled, and the erythroid response was evaluated as an increase of equal or more than 1 gram per deciliter. And you can see that 77% of the patients on luspatercept achieved the primary endpoint compared to 0 in the placebo group. But you can also see that in a follow-up, almost 50% achieve also an increase of hemoglobin equal or more than 1.5. And with this data from the BEYOND study, luspatercept has been approved by EMA in 2023 to treat anemia in non-transfusion dependent beta thalassemia. These are also data presented a few months ago at ASH by a group of researchers, including Olivier Hermine, and they wanted to show how some biomarkers of ineffective erythropoiesis and the iron homeostasis are associated with response to luspatercept. Here you have the data at baseline, retics, transferrin receptor, LDH, GDF11, hemoglobin F, EPO, ERP, and hepcidin. And without going into details, I can summarize that the primary endpoint responders, so those who respond to primary endpoint, had significantly lower baseline level of reticulocytes, of transferrin receptor, of LDH, of GDF11, hemoglobin F, and EPO, and had higher hepcidin level compared to those non-responder. And again, there are some biomarkers that of ineffective erythropoiesis and iron homeostasis. You can see here GDF11, GDF8, E15, serum ferritin, retics, and hemoglobin. And for not making the long story too much, I just say that the level of GDF11, which is a member of the transforming growth factor superfamily ligands, were significantly reduced at week 48 in the treated patients during the treatment compared to baseline, whereas there were no significant differences between respondent and non-responders for other parameters. And definitely in luspatercept responder, there was a significant reduction in spleen volume at week 48 compared with baseline. Some of the markers I just mentioned, they modified in the long-term follow-up, suggesting that treating patients with luspatercept, we should be patients, not stopping the treatment immediately after a few weeks if the patients are not responding. So we have to inform the patients that the response may take some time and to monitor some parameters to see if they start to respond. Anyway, just to summarize, the biomarker analysis performed on Beyond suggest that patients with non-transfusion dependent thalassemia receiving luspatercept had an improvement of some biomarker of ineffective erythropoiesis, and leak, so the liver iron concentration was not significantly changed. However, there was a reduction in serum ferritin, and that also was an initial sign of changes on iron dysregulation. With this slide, which has been published in Blood a few months ago, you can find the paper by Saliba et al., How I Treat Non-Transfusion Dependent Beta Thalassemia. We have a summary of the state of art for treating the ineffective erythropoiesis and consequently the anemia and iron overload in non-transfusion dependent thalassemia. And you see that on the left part, to improve the hemoglobin level, you may have blood transfusion, but of course is something that we want to avoid in these patients. So you have the luspatercept approach, and on the right side is the state of art for treating iron overload. But is it enough? Not yet. The state of art allowed us to talk on other, let's say, approaches for treating thalassemia. And this approach is focused on improving, let's say, the metabolism and lifespan of thalassemia red cells. And for this approach, we have in an advanced stage of development a PK activator, which is named mitapivat. Why PK activation may represent a mechanism of action to improve the metabolism of red cells? You know that the 2,3 DPG is extremely important for the, let's say, metabolic function of red cells, producing energy and transforming ADP in ATP. And for this step, for this pathway, pyruvate kinase is essential. In a normal red cell, according to the cellular demand, the PK work and allow the production with ATP, able to meet the cell demand of energy. In subjects who carries the PK deficiency, and so the ATP production is reduced, the demand of cells, it remains as usual, but there is an inadequate response to this demand, an inadequate production of ATP, and this lead to an increased red cell destruction, leading to chronic hemolytic anemia. And this is the situation of PK deficiency. And this situation, in presence of normal white type PK enzyme, may occur in those situations where the cellular demand is increased. So there in cells where an increased demand of ATP is there. And this is the case of many other hemolytic anemias, including thalassemia. So there is normal PK, but is not sufficient to meet the cellular demand. And in this case, as I said, there is a need of stimulating the production of PK in order to increase the production of ATP. And mitapivat, which is the inducer of PK, was recently approved by FDA for the treatment of patients with PK deficiency, and I can confirm that has been also approved recently in Europe. So with this in mind, the idea was, why not trying mitapivat in a situation like thalassemia, where the energy or the activity of red cells require a higher production of ATP. So these are the results. I try to shorten presenting only the results of the phase 2 study, which included 20 patients affected by alpha and beta non-transfusion dependent thalassemia. This is the first study including the alpha thalassemia, the hemoglobin H patients. And you can see that there is an increase of hemoglobin in the core period, 24 weeks. And then this increase of hemoglobin was maintained in a long term follow-up up to 72 weeks. And once again, at the EHA in a couple of weeks, further data will be presented. But interestingly enough, and sorry for the Italian slides, but you can see changes on markers of erythropoiesis, such as erythropoietin, erythroferritin, which decline as expression of a reduction of ineffective erythropoiesis, reduction of bilirubin, again, as expression of hemolysis, and variation of ratio between retics and erythrocytes in favor of an improvement of erythropoiesis. So these data are very impressive, and at present, so the state of art is that in this also is an interesting review of these compounds published in the book of the educational program of ASH last December by Kevin Koo. And the state of art is that now for non-transfusion dependent thalassemia patient, there is a phase 3 double-blind trial ongoing, including 171 patients. And for TDT is ongoing, a phase 3, including 240 patients. The enrollments are close, and the observation data are ongoing. There is another compound which works like mitapivat. I forgot to tell you that mitapivat is an oral drug taken daily, twice daily. And this etavopivat, which more or less is the same mechanism, is giving once daily. And the clinical trial are ongoing, as you can see here, not only in thalassemia, but also in sickle cell disease and in anemia in MDS. So this is the state of art for this third target, the metabolism of red cells. But still, we have another possibility for thalassemia, which was explored with, let's say, not encouraging results. And this target, in this case, the target is the iron metabolism. So there were, during the last few years, several approaches for control the dysregulation of iron, with the idea of generating an iron-restricted erythropoiesis, which may affect the anemia in thalassemia. One approach was to use stimulators of hepcidin. But that was actually such as tempura 6, for example, or using some antisense or oligonucleotides or small interfering RNA targeting tempura 6, but both were unsuccessful and were stopped. Another possibility was to inhibit ferroportin. Ferroportin is the only exporter of hepcidin, and even this trial using the recombinant ferroportin, but wasn't actually effective, and it has been recently stopped. Or hepcidin mimetics trial, but again, to my knowledge, this trial have been stopped for no significant results, and no other plans, to my knowledge, are available for future development. So I am at the end of my presentation, where I try to update you on the scenario for future treatment of thalassemia. This slide is only theoretical, but is just to show you that having a managing approach to thalassemia or other hemolytic anemias opening day by day, as it was for some oncohematological disorder, we may reach a point, of course, in years' time, where we may combine different therapies in order to increase the efficacy of one drug, maybe using two drugs or combining a drug with bone marrow transplantation or with gene therapy. This is the future, of course. It has to take into account not only efficacy, but also safety. And the last but not least, although it's not our job, but the cost of this treatment, and that has to be the discussion point among the authorities. With that, I want to thank all my collaborators in Milan, but especially I want to thank families and patients who actually participated not only in the luspatercept study, but in any ongoing clinical trial which will provide us further results. With that, I stop here, and I will be happy to take any question.
Thank you, ma'am, for that fantastic talk, as always. It's always worth to listen to you. And I now request all our discussants to please put the raising signs so that we can start our question answer session with Dr. Maria Capellini, ma'am. So in the meanwhile, yeah, sir, your question, please. Yes, sir. Your question.
Thank you, sir. Yes. So, madam, thank you for this nice presentation. So I have one question: how you deal the thalassemia patients who develop alloimmunization after repeated transfusion?
This is a very good question, and is the case, at least in our experience, is mainly the case of patients who are transfused irregularly or who start to transfuse late. In the past, not having other possibility, I used to treat this patient with hydroxyurea, to start hydroxyurea, and actually that's allowed to increase a bit the hemoglobin level, but also to be able to better manage the selection of blood to be transfused. Nowadays, actually, for these patients, we try luspatercept. I have so far few patients in this situation, and they respond. Of course, we need a longer follow-up, but that can be a possibility.
Madam, do you use steroid or rituximab, or upfront you choose for splenectomy?
Okay, steroids were, of course, a kind of treatment or supportive care associated to hydroxyurea, as I mentioned. I try also originally the rituximab, but actually, you know, it was difficult to manage because the efficacy was limited on time. So I had in a very, very severe case, I remember, where I was almost losing the patients, I combine steroid, erythropoietin, rituximab, and all together they actually give us some possibilities.
Thank you, madam. Thank you.
Thank you, Dr. Ashutosh. Dr. Narendra Chaudhary, your question, please.
Yeah, thank you, madam. Actually, my question is, if a child with thalassemia don't have match-related donor for transplant, but every child will have haploidentical donor available. So in such case, how do you decide in between haploidentical donor transplant versus luspatercept?
There are data, although not conclusive, but there are data on haploidentical donors, and you know, it depends also on the experience of the transplanter center, because some are more experienced and they know well how to do conditioning and so on compared to others. The major point so far is that luspatercept is approved from the age of 12. If our children or child below the age of 12, luspatercept is not yet approved. So if he's over 12, I will say start with luspatercept, see how it responds. If it's responding well, done, okay. If you have no response or significant side effect, you may go back to the transplant. So transplant, it remains an option if you have a failure with other approaches, luspatercept, and soon, I hope, with mitapivat. Last possibility, but of course, it's very costly, is the gene therapy. And gene therapy is, again, so far, or genome editing, even better, approved from the age of 12, but it will be soon available also in children. But there is a problem of cost, of course. But I will try luspatercept first and then move back to the idea of transplant.
Thank you.
Thank you, Dr. Narendra. Dr. Sandeep Bartaki, your question, please.
Thank you, Dr. Capellini. My question is, there are some encouraging studies from India and China about thalidomide in thalassemia. So what is your take on thalidomide, the benefits and the risks involved?
This is a question which was asked also last time. There are some encouraging results. Unfortunately, we are missing a proper clinical trial. So mostly are sporadic cases, and we are missing data on long-term observation, especially for side effect, teratogenesis, and so on. Let's say that alternatively to thalidomide, I prefer to use hydroxyurea, because for hydroxyurea there are masses of data on in other conditions like polycythemia vera and so on, where the side effects are limited. Of course, not many patients, at least in my experience, respond to hydroxyurea among thalassemia, of course. I'm not talking of sickle cell disease. Personally, I have no experience with thalidomide, but as I said, we probably need to collect more data. And if you have data in India, try to collect all them and publish good data to support the idea.
Thank you.
Dr. Rajat Bhattacharya, your question, please.
Thank you for a fantastic presentation. I'm going to be a bit esoteric and ask you a practical problem. So every day almost I see children with transfusion-dependent thalassemia, but not able to afford treatment. And now we are talking about curative treatment with transplants and gene therapy, which are very costly. So see a gap between availability and the needs, especially in the developing countries. So what is your advice to politicians or countries? How do they solve it? Because I think that's a big problem. We have facility for transplant. We probably will develop gene therapy, but the cost is not reaching problem. So what is your advice?
You are perfect. This is something which is touching my heart, because science goes, progresses, but then we are not able to afford it. My hope is to increase the awareness of need among politicians, but particularly my message to pharma is to, after an initial time where they have to face, of course, the cost of development, but my message to them is to drop the cost or the way to pay in order to make this treatment available all over the world. Of course, in selected cases, because not all the patients may benefit, particularly those in advanced age with several complications, but for the young people. It happens, for example, for CAR T treatment. At the beginning, they were very, very costly. Now the price has been reduced significantly. So my hope for the future is to have this available. In the meantime, our duty, our job is to increase the awareness, even among politicians, that these children, these patients, even young adults, need to have a, let's say, save life treatment. But it's not, unfortunately, up to us be able to do a reduction of cost.
Thank you, Dr. Rajat Bhattacharya. Any other question, Dr. Rajat, sir?
No, that's it.
Thank you, sir. Dr. Shruti Kakkar, ma'am, your question, please.
Dr. Amit, thank you, Dr. Capellini. It's always a pleasure to listen to you. I had a question. There's so many new drugs which are coming up, like luspatercept and metaviptat. So do you think in future, in patients who do not respond or partially respond to one drug, can we kind of combine these two? I mean, do you think that's a possibility in future and get...
Yeah, I mean, that's what I summarized in my last slide as a future. In theory, I really believe that, for example, luspatercept and mitapivat may benefit together because with luspatercept, we are increasing red cell production. But of course, these red cells require to be, let's say, very live and active, and mitapivat may give this energy. However, this so at present is a dream, because first of all, we need to have all these drugs registered. We cannot use them if they are not registered. And then I don't believe that pharma will design any clinical trial using a drug which are produced by another pharma. So that will be our commitment, when the drug will be registered, to design small but well design trial to see if they act in a synergistic way or additive effect. So I don't think will be possible in 1 or 2 years. It will take more, but it will be possible.
Thank you, ma'am.
Thank you, ma'am. Dr. Priyanka Samal, your question, please.
Yeah, thank you, ma'am, for that lucid talk. And there are two questions which we come across in our day-to-day life, like management of alpha thalassemia patients who present as NTDT. How do you manage such patients? What are the drugs you would prefer for them, or just transfusion?
That is a good question. And as I mentioned, mitapivat had a clinical trial including alpha thalassemia patients who responded very well. The 5 patients in the phase 2 trial with hemoglobin H disease, 100% responded. And I also have been informed that there are new trials just starting with luspatercept enrolling alpha thalassemia, but yet none of the drug has been approved for alpha thalassemia. So what to do in the meantime for those who have severe anemia? I think that the only way is to transfuse and to chelate them, to have them ready for treatment with one of these drugs whenever approved. But that will be, I believe, quite in a short time, because mitapivat is in an advanced stage also for alpha thalassemia. So hopefully in 1 year or so, we may have mitapivat available for alpha thalassemia.
Thank you, ma'am. And for the NTDT, sickle beta thalassemia, any data supporting luspatercept in those patients?
Sickle thalassemia, you mean?
Yes,
double heterozygotes?
Yes.
Not registered, but actually luspatercept, if I'm right, has also an ongoing trial on sickle. Is out is off label. If you are going to use it, so far is off label. I have no experience. I have no patients treated with sickle and thal. In theory, it should work, but so far we don't have data. So if they are severely anemic, you should use transfusion or hydroxyurea. So far you can treat them with hydroxyurea.
And madam, the last question is like the previous question regarding the alloimmunization. How would you use hydroxyurea at what dosage and erythropoietin and what dosage in patients who are alloimmunized?
So for hydroxyurea, I start usually with 20 milligram per kg, increasing the dosage to 30, but not much more than that. Erythropoietin, I don't use erythropoietin as a standard when I'm using hydroxyurea. I mention erythropoietin in a very, very severe hemolytic patients, but it's not, let's say, part of the scenario, because erythropoietin is also stimulating the ineffective erythropoiesis. So I try to avoid erythropoietin. Whenever I am in real serious trouble, I add for a short period of time 10,000 units twice a week, but for a limited period of time.
Thank you so much, ma'am.
Thank you, Dr. Priyanka. Dr. Sonali Mohapatra, ma'am, your question, please. You're muted, ma'am. Please unmute yourself.
Thank you, ma'am. That was an excellent talk. So, being in India, we come across a lot of patients who have massive splenomegaly. So, how is your experience with splenectomy in these patients? So, do we try with like upfront splenectomy or try to optimize the transfusion therapy?
I try to avoid as much as possible splenectomy, because in the past, back to the 80s, I remember that the first approach was to splenectomize the patients. But then we found a lot of consequences, including thrombotic risk, many complications. So today, my suggestion is try to avoid as much as possible splenectomy. But to do that, you have to try to prevent the development of splenomegaly. And to do that, the right way is to improve or optimizing the blood transfusion. These patients develop huge splenectomy because they are maintained with a low level of hemoglobin, although they receive some unit of blood, but very often they have an hemoglobin level below 8 or something like that. So the patients who are regularly transfused with a pre-transfusional hemoglobin between 9 and 10, they don't develop splenomegaly, and you don't need to do any splenectomy. So first, try to optimize the blood transfusion.
Yes, ma'am. And my second question is, do you frequently use growth hormone replacement therapy, like for short stature and delayed puberty?
Always. So we do the oxologic evaluation. So we have dedicated endocrinologist, and we are implementing the endocrine treatment according to the situation. For example, if they are hypogonadic, of course, at the right age, we are give hormone replacement, all these kind of things which are evaluated by the endocrinologist. Again, I have to say that this was mainly the case for those patients who were not properly treated with transfusion and iron chelation since an early age. For if you are a pediatrician and you are dealing with newly diagnosed or young children, if you are putting these patients in a right standard of care, you don't have development of such endocrine problem. If you have, you have to evaluate the patient with the endocrinologist and set up the proper treatment.
And ma'am, last one, your experience on combination chelation therapy.
Yes. Again, this is the case, not for all the patients, but for those patients who have a very severe iron load, particularly heart overload. So they have a increased iron in the heart. So in such cases, especially if the patients are at risk for heart failure, I start an intensive iron chelation with desferrioxamine by pump and the ferripron, usually the ferripron. It can be also the ferrazirox. This intensive chelation is maintained till the ferritin, or better, the MRI values drop, and when they are acceptable, I go back to monotherapy. So the objective is to keep the patient on monotherapy. I use combine when there is a high risk. But for not reaching the high risk, once again, you have to put your patients in a proper iron chelation as soon as possible with the right dosage and make sure that the patient is compliant to the treatment.
And ma'am, your experience of hydroxyurea in alpha thals.
Let me think about it. We don't have too many alpha thal. I don't have personal experience, and I'm not sure there are data in literature, but you can try. Why not?
Okay. Thank you, ma'am. Thank you.
Thank you, Dr. Sonali. Dr. Nita Radhakrishnan, your question.
Thank you, ma'am, for that wonderful talk and painfully answering all those questions we have been putting to you. So I have two questions. One is regarding luspatercept, the thrombotic risk. So thrombotic risk in patients who are non-transfusion dependent versus transfusion dependent. What is the difference? And now when the trial opens for 6 to 18-year-old age group, will antithrombotic therapy as an aspirin prophylaxis be advised for those patients also?
Okay, so we actually describe an increased risk of thrombosis in non-transfusion dependent thalassemia patients, particularly in those splenectomized. This was described by us and others before luspatercept. And the explanation for that is variable because there are many factors involved. But for my experience, one of the major risk factor is splenectomy because it allowed an increased number of nucleated red cells in peripheral blood. Nucleated red cells behave like platelets because they expose phosphatidylserine on the membrane. So this is the starting point. And TDT patients have less risk because they are transfused, so the peripheral blood is better. What with luspatercept? With luspatercept, actually, we reported in the BELIEVE trial, so transfusion-dependent thalassemia patients, I don't remember exactly, 6 or 7 cases of thrombosis. But when I reviewed those cases, all of them already had a previous events of thrombosis, and they were patients with multiple factors which could have been responsible for thrombosis. Whereas we didn't observe thrombotic event in beyond the study. We were expecting to have cases on the anti-DT, but we didn't. So what is my suggestion? First of all, I will be a bit skeptical to give luspatercept to patients who already had repeated thrombotic events or who have several complications, who have several risk factors, obesity, smoking, you know. In these cases, I will be a bit skeptical. If a patient had, let's say, a lady had a peripheral thrombotic events a year before, I don't see the risk. In case, I will give anti-aggregants like baby aspirin, or in some cases, some prophylactic treatment, but that is limited to patients who really have many risks for thrombosis. But per se is not a factor excluding the treatment with luspatercept.
Adding, so when in luspatercept, it is found to be more clinically more effective for NTDT patients than in TDT, right? Because that rise in hemoglobin is for a clinical outcome, it is more helpful, transfusion independence, etc. in NTDT. Similarly, mitapivat is more helpful, as in I think it is licensed for use in patients who do not have, as in who do not have two missense mutations, as in if you have more severe mutations, it will not act as such. So when now itapivat is coming in clinical trials, do you see benefit more in beta plus mutations rather than in beta not, or is it a completely different?
Data will be presented at THA actually. There is no relationship between response to mitapivat and mutation. So even patients with beta 0 mutation, they respond. The phase 2 study was conducted in non-transfusion dependent thalassemia beta, and there most of the mutation were mild beta 0, but mainly beta plus. In the Energize T, which is the trial on TDT, even beta 0 mutation respond. So far, we cannot say that there is a relationship. Let's see when the result will be available.
Thank you. Dr. Kapil Garg, your question, please.
Thank you, Dr. Maria, for a wonderful presentation.
Thank you.
In our part of world, majority of patients cannot afford luspatercept and other investigational therapies. So how do you see the role of hydroxyurea in this part of the world, in thalassemia and transfusion-dependent thalassemias?
So you are asking the combination of luspatercept and hydroxyurea? Is this the question?
No. Majority of our patients cannot afford luspatercept.
Okay.
So what is the role of hydroxyurea in patients who are having
Okay. Well, you know, for hydroxyurea in thalassemia, there are some data, particularly from the Iranian colleagues. They treat since long time, back to more than 10 years ago, thalassemia patients with hydroxyurea, and they claim that some became transfusion independent, or those with anti-DT increase the hemoglobin. But these data were not seen in other cohort of patients. We didn't see these results in our cohort of patients, as well as other group didn't observe it. And I had the opportunity to review some data of the Iranian cohort. Actually, they increase a bit the hemoglobin, and apparently they didn't transfuse anymore, keeping an hemoglobin around 8.5, 9 gram. But they become severe thalassemia intermedia. So there was a benefit, but associated to a lot of comorbidity. Of course, we have to keep in mind that some countries cannot afford novel treatment, so something is better than nothing. If you have a good the possibility of having a good standard of care with blood transfusion and iron chelation, these remain the milestone. Hydroxyurea can be an alternative, but not sufficient to properly treat the patients. This is my point of view. It depends on what you can do. Hopefully, the novel treatment will become more and more available at less cost, so they can be used. In the meantime, if you select some patients for hydroxyurea, you can try.
So you didn't see a response with the hydroxyurea in your cohort, even if they
No.
had XMN polymorphism?
No, really. As I mentioned, I have a few patients to whom I give hydroxyurea, but just because they have big extramedullary hematopoiesis masses, particularly those paraspinal, because hydroxyurea keep them, let's say, less active, and so there is a positive results in terms of, let's say, extramedullary hematopoiesis masses effect on the neurological, from the neurological point of view, but not in terms of increasing hemoglobin. So I don't see any result with hydroxyurea for increasing hemoglobin, even in those with XMN.
Okay. My other question is, because our patients are having very irregular transfusions and starting transfusions very late, so elimination is very common. So can splenectomy be of any help in these patients? Because sometimes it is so difficult to manage these patients, and
again, splenectomy bring the risk of several complications, but particularly thrombotic events, even after some time of splenectomy, not immediately. So I'm not in favor of splenectomy, but of course, you said some of your patients start to be transfused late. If you don't have alternative. In some cases, there are experience on partial splenectomy. I don't know if you have experience on that. Maybe you can discuss with your surgeons instead of doing entire splenectomy to do partial splenectomy.
okay. And another question is about a combination of chelation therapies. Have you combined all the three chelators in any of your patients?
You mean three chelators altogether?
Yeah.
No, I try to combine two. Either the sferrioxamine is always there. I can use the ferripron or the ferazirox. I don't have any patients, and frankly speaking, I don't advise to use 3 chelators altogether. Also because I still keeping saying that you have to start to chelate the patient as soon as possible and better as possible in order to avoid severe iron load, because then it's difficult. I mean, patients have problem in taking multiple iron chelators, and the consequences can be also in terms of safety.
Okay, thank you.
Thank you, Dr. Kapil sir. Dr. Nivea Thanda, your question, please.
Thank you again for your lecture, Dr. Maria. We have a few patients who develop EMH. So yes, we have to, in this patient, we have to raise a pre-transfusion hemoglobin level. So I like to learn the management of such kind of patient from you and from your experience.
Okay.
Please share.
Okay. Usually patients who developed EMH are patients who are kept with low level of hemoglobin. So first of all, if the detection of EMH is occasional, just because you perform an X-ray or something and the patient is asymptomatic, the best way to proceed is to establish a regular transfusion regimen in order to follow the guideline to keep the pre-transfusional hemoglobin between 9 and 10. If the patient is symptomatic, so often they complain neuropathy, peripheral neuropathy, or problem on breathing and so on. What I do is to combine two treatments, as I already said before, hydroxyurea, because in these cases, hydroxyurea has mainly the function, the role of controlling the development or the increase of the masses more than increasing hemoglobin. I don't care about hemoglobin with hydroxyurea. I try to keep the hemoglobin by transfusion, but hydroxyurea is useful for keeping the masses contained, so not increasing and not increasing. Sorry, I lost. Okay.
Yep.
Can you hear me?
Yes, ma'am.
Yes,
Okay,
yes, of
because
course.
I lost you. No, I will say, okay, that the hydroxyurea has this function and is associated to transfusion. I am not keen on using radiation. If you look at the literature, you can find
what I like to
suggestion to do irradiation of these masses. Very often they are located also in difficult position, and I'm not really keen on performing radiotherapy, as well as I'm not keen on performing surgery, of course, removing that. So my first approach is transfusion and hydroxyurea.
Thank you very much.
Thank you, Dr. Nivea. Sir, Agarwal, sir, your question.
Thank you, Dr. Nika, for wonderful question and answer session. I have a couple of questions about LUSPA. So now you have a very large experience worldwide. So what has been the ultimate? What percentage of patients have become transfusion free for long period, both in anti-DT and transfusion dependent?
Okay, in NTDT, we have the increase of hemoglobin up over 1.5 gram, which is increasing in terms of patients number more and more in a long-term follow-up. So we are expecting to achieve in these patients hemoglobin level above 10. And I should say, I don't have the global data yet, but in my experience and other groups, I can say that over 70% of the patients had an increase of 1.5 and almost 50% reach more than 10. Of course, this depends also on the baseline hemoglobin level. For those who start from, for example, 8.5, it's easier to reach more than 10. So in NTDT, I'm quite confident the response is good. For TDT, in my cohort of patients, and now we have almost 80 patients on LUSPA, we had 8 patients, so which is 10% or something, who are transfusion independent for at least more than 20 months. So that is a sustained response. And we have few other patients, I don't remember exactly the number, who became transfusion independent for a while. Let's say if they used to transfuse every 3 weeks, they could have been transfusion free for 12 weeks or something. Then they require a unit of blood, and then again they maintain a good level. So they fluctuated a bit, but the reduction of transfusion is much more than 50% compared to the baseline. So I think that just to going back to one of my comments, the long-term follow-up is important, and the suggestion is to be patient and see, because some patients may respond late.
Thank you. Thank you.
Thank you, sir. Ma'am, we have got couple of questions from the audience. Dr. Pushpanjali wants to know what should be the treatment plan for a 6-month-old child, first child of a couple having one parent has thalassemia minor and the baby has got thalassemia major, now kept on monthly blood transfusion. 6-month-old child.
6 months old, only one parent is carrier, the other one is normal.
Both the parents are thal minor, the child is thal major.
Okay, so it's a typical thalassemia major, and usually at 6 months they start to be very anemic, and I suggest to start transfusion, of course, to wait after a number of transfusion, and then to start chelation even before the age of 2, in order to avoid iron accumulation. Of course, before the age of 2, you don't have the possibility of using an oral chelator, so unfortunately has to start the sferrioxamine with the pump, but as soon as is over 2, it can start oral chelator.
Thank you, ma'am. Another question from Dr. S.K. Sharma. There is increased risk of hepatocellular carcinoma in transfusion-dependent thalassemia. At what age do you start the surveillance for hepatocellular carcinoma?
Well, usually our patients over 40. And unfortunately, we found a higher number in non-transfusion dependent thalassemia patients because they were not chelated and they accumulated a lot of iron in the liver. But anyway, we keep in our thalassemia patients over the age of 10, we perform regularly over other year in abdominal ultrasound in order to monitor the liver, and possibly after the age of 10 also a MRI for liver iron concentration. Some people use to monitor the risk the measurement of alpha-fetoprotein. I don't do it because it's not, in our experience, really reliable. Anyway, the risk of hepatocellular carcinoma is definitely in young adult patients over 30 or something like that. Of course, those who are also hepatitis C positive have an increased risk compared to those who are hepatitis C negative. So monitoring abdominal ultrasound every other years over the age of 10, monitor the liver function test at least once a year.
Thank you, ma'am. Another question from Dr. Yimon Tent. Any experience of using iron chelators during pregnancy? If the benefits outweighs the risk, and if so, which chelators with minimal side effects do you prefer in pregnancy?
Well, in pregnancy, it was advised to use the spheroxamine, but usually in the third trimester. And still, that's what I do. Nevertheless, since so the suggestion is to keep well chelated the patients, and if they are well chelated with a ferritin level below 1000 and possibly below 800, they may stay out of chelation during pregnancy and restart a proper chelation with the oral chelators after pregnancy.
Thank you, ma'am. Another question is, will you give iron chelation in thalassemia intermediate patient with cardiomyopathy despite normal ferritin level?
Oh, yes, that is a very important question. I had the opportunity to tell you, and you have read in many papers, that ferritin level in non-transfusion dependent thalassemia is not really reliable, because for the same liver iron concentration, you may have lower level of ferritin in NTDT than TDT. So there is a nice paper by Dr. Taher, and we collaborated with, showing that for 800 ferritin level in NTDT patients, this is already a sign of iron overload. And you may start iron chelation. So the Ferazirox, the Thalassa study, showed well that NTDT patients, according to age, according to ferritin level, are severely iron loaded, especially in the liver, and they require chelation. And the Ferazirox is being approved for NTDT. So they should be treated, absolutely. Of course, the scheme of chelation should be different than TDT, because these patients are not receiving regularly transfusion. So you have to monitor carefully the ferritin to see when it goes down. You may stop or you may reduce the dosage. So you have to play with the iron chelation in order of not over-chelating.
Thank you, ma'am. Another question from Dr. Neeta Radhakrishnan. Is there any incremental effect of luspatercept over years of use? Does hemoglobin increase or does it plateaus off after the increase of 1 to 1.5 grams once it increases?
So the question is,
is there an incremental effect of luspatercept over the years of use? So once the hemoglobin rises up, then it plateaus or
okay. We have to base our comment on data available. And so far, we have some anti-DT patients who are on treatment since then 8 years. I mean, when I started the phase 2, my first patient was an anti-DT, and that's back, I think, 10 years. He's keeping his hemoglobin around 11, very happy, no side effect. So we don't have many data on very long term, but we can guess that the response will be maintained.
Thank you, ma'am. Another question is, if the patient has hepatitis C and has been well treated and has got now negative viral RNA, do they still have increased risk of hepatocellular carcinoma in patients with thalassemia?
That is a question not only for thalassemia patients, but for the general population. There are evidences, unfortunately, in general population that patients treated for hepatitis C, negative for becoming negative, they may develop hepatocellular carcinoma. Is that because of fibrosis, which remain there, which is, I don't know yet what is the response. The risk, it remains.
Thank you, ma'am.
For thalassemia, we don't have data yet, but I don't see why it's not different than general population.
Thank you, ma'am.
I think, what time are we closing, just to have an idea?
Just 1 or 2 questions left, ma'am.
Okay, thank you.
So, question from Dr. Amit Kumar. In your practice, when you go for approach for splenectomy in thalassemia major patients?
When?
In your practice, when do you go for splenectomy in thalassemia major patients?
I try to avoid, since the last 15 years, I didn't perform any splenectomy in thalassemia major. I perform 2 splenectomy in thalassemia intermediate, in anti-DT, adult patient who wanted to become pregnant, and the spleen was so huge that we decided to remove, performing prophylactic treatment for infection, of course, but also prophylactic treatment for preventing thrombotic risk.
Thank you, ma'am. And the last question is that has been asked by a thalassemic patient. Actually, they have kept on asking in the chat box that the patient he has been on thalidomide and hydroxyurea for a couple of 7 to 10 years and off blood transfusion, and has been developing leg ulcers since last 5 to 6 years, which is not resolving. So, any comment whether what can be done for these leg ulcers?
Treating the leg ulcers when are there is very, very difficult, and sometimes is also very painful. There are different approaches. I don't have many, so I don't have personal experience. In some cases, they use platelet plasma concentrate. In some cases, they use, some treatment used for diabetic patients who develop ulcers, but I have no personal experience. I have to say that in the early time of luspatercept in phase 2, in the clinical trial, we saw 2 or 3 patients who started with leg ulcer, and they were improving, and in one case was completely resolved with luspatercept. So that can be a possibility to try. I don't promise any response, of course, but that can be tried.
Thank you, ma'am.
I just want to add, when the patient is on hydroxyurea and they get the leg ulcer, the only solution is to stop hydroxyurea.
Exactly.
Within 6 months, the ulcers heal up totally.
Yeah.
And
Because
this is
hydroxyurea is actually, there are conflicting data. Some, as you said, suggest that hydroxyurea can cause a leg ulcer, some other, but I agree, to stop hydroxyurea is a good approach. Yeah.
Thank you, ma'am. Thank you, sir. There are no more questions in the chat box, and I've finished all the questions from the discussions. Well, thank you so much, sir.
I just want to answer one question. Somebody is saying that D-ferriprone is not available. D-ferriprone is available. It is through CIPLA, and there are outlets in each major city. You have to approach CIPLA to get it. It's not in the shops. So it's easily available and at a very low cost.
Yeah. Yeah.
Thank you, ma'am. And one last question just popped up. Can we go for deferoxamine without pump? Subcutaneous deferoxamine
No, because intramuscular is so painful, no, and less efficient. So you can do only by pump.
Thank you, ma'am. That's all, ma'am. Thank you so much, ma'am, for that wonderful question association and a fantastic talk as usual, ma'am. Thank you for being with us today. It's always a great learning from you, ma'am. Thanks a lot.
It's a pleasure for me. It's always nice to see friend faces. So I wish you a good Sunday, and hopefully we will see in the future. Thank you. Bye. Bye.